A very, very high-profile medical doctor continues to get fundamental biology of aging literature wrong and presents it incorrectly. I can't help but ask myself, is it that they don't know better, that they do know better, and they choose to keep presenting bad information?
My wife said, this is a daft idea, no one will ever listen to you.
What does she say now?
Well, yeah, she says, yeah, I was wrong. We were still left with about $150,000 shortfall for the study. And that's where my wife let us remortgage our house.
Wow. How we understood the surface of the earth in 500 BC. I sort of feel like that's kind of how we understand the biology of aging today. There's a lot that we don't understand. If we were really getting closer to solving aging, we ought to be able to increase the lifespan of a mouse by more than what Rick and Roy did 50 years ago, and we aren't doing it.
I think one of the biggest concerns I've got is
no doctor should be recommending these tests. Hey guys, look who I ran into at the Longevity Investors Conference in Gstaad, Switzerland. Brad Stanfield.
Yeah.
This is the first time we've met in person. I've been on your podcast a couple of times, and we've done some other stuff together, which I'm sure we'll talk about. But it's great to be able to connect in person, and I think we're just going to talk about whatever comes to mind and see where it goes.
Yeah, absolutely.
So probably, a lot of people watching this will know of you or have seen your podcast, but may not know much about you and how you sort of got interested in this space. And I'm going to say longevity, but I'll let you use a different word if you want to. But maybe you can just talk about, your background and what you're doing now and how you got into what you're doing with your YouTube channel and in your day job.
Yeah, so my day job is a primary care physician in Auckland, New Zealand, but how I got to that stage is a bit of a journey. So when I was a junior doctor working in the hospitals, I started to notice some wrinkles around my eyes. And that was actually the start of my journey looking into aging and trying to figure out, are we closer to figuring out ways to slow down the aging process? What can we do about wrinkles? And yeah, are there any breakthroughs underway? And that's when I started to look into Metformin, to IGF-1, and that kind of started my journey. In terms of how I became a primary care physician, so I had the daft idea that I wanted to become an orthopedic surgeon. So I was at one point helping to fix, broken bones, broken hips. So I did that for about a year, but I realized that lifestyle wasn't quite for me. So I took a year out and I started to work in the emergency department. And through that, I just was thinking, I am really interested in this aging process, but I did want to try and bring some science to this field because I thought that in terms of the way that all of this was communicated, particularly the health information online, there was just so much misinformation out there. So what people would do is extrapolate single cell research and say, look what happened in the single cell, therefore we should be taking this supplement or doing this.
You still see that a lot.
100%. So that was the impetus for me to start my YouTube channel. And then sort of one thing led to another. I had no idea that it would be, that it would grow or that people would listen to me. Actually, my wife said, this is a daft idea. No one will ever listen to you. You shouldn't do this. But
what does she say now?
Well, yeah, she says, yeah, I was wrong. That's the only time that I've ever heard her say that. But no, she's been really supportive along the way.
And when did you start your YouTube channel?
Yeah, so it was end of 2019.
Okay.
So that was in between.
Wow, right before COVID.
Yeah. So, and I was actually working in the emergency department at the time. So my earlier videos, which I've now removed from YouTube because they don't look particularly good. I was sitting on a couch in one of the living rooms, actually staying at a hospital residence because I was helping with the emergency department in one of the local hospitals there. So they put me up in a residence. So yeah, that was kind of the beginnings of the YouTube channel. So after a night shift, I would start, recording YouTube videos. So. Yeah, and one thing's led to another.
Yeah, I mean, your YouTube channel has done great. I don't know how many subscribers or views you have now, but way more than the Optispan podcast. I mean, I wonder, do you have a feel for what do you think led to the success of the YouTube channel?
I think people were craving human-led clinical trials in terms of having that communicated to them. Like I was saying, there's just so much health misinformation out there, and people tune into this type of content because they want to be healthy. They don't want to be misled. So I think people appreciate that I'm quite guideline driven, as in, the primary care guidelines, and I'm sure we can talk about this in a bit, they are wonderful. The trouble is most people, particularly the public, don't know about these guidelines. So trying to get that information out there and democratizing that access to the clinical guidelines, and hopefully not a too dreary way, Yeah, I think people have appreciated that approach.
Yeah, and I think, I mean, one of the things I've appreciated, and I've never told you this, maybe I shouldn't, but you know, and I know your style of video has changed, and I'd be interested to get your take on that. But when I first saw your videos, this was probably before you even had me on your podcast the first time. I had to get past a little bit of the kind of YouTube presentation and get to the content. And one of the things I've really liked is, unlike I think a lot of people who are out there producing content in this space, yours is very data driven. It tends, in my view, not to veer off into the less scientific, and really try to focus on, you know, how can we understand the state of knowledge given the studies that are out there today, right? If anything, you're more conservative when it comes to presentation of science than I am, which I think a lot of people, you know, may not recognize, right? But anyways, I just wanted to tell you that I mean, I really like the fact that unlike a lot of people in this space, you take a very rigorous approach to the way you present new studies.
No, I appreciate that. One of the things that I'm actually quite scared when I publish a video in case that I've got something wrong, because I know that, yeah, now with the channel presence that I do have, if you start to make mistakes and people follow that advice, you know, it's not a good look. Particularly, you know, since I'm a practicing physician, I want to make sure that, you know, that the advice that I'm giving to, you know, on YouTube is the exact same advice that I'm giving to a patient sitting in front of me at the clinic. So, you know, if I'm making mistakes on YouTube, you know, potentially making mistakes with my patients as well. So, I try and be very, very careful. And this is why I'm always double checking what the clinical guidelines show, making sure that I haven't missed a particularly pertinent clinical trial that's been done, and focusing on the randomized clinical trials. Because that's another thing that, even if you are quoting human studies, people will often quote observational data. So a classic one is, you know, vitamin D or magnesium. There's a truckload of associative data out there, showing, you know, all of these wonderful benefits for cardiovascular disease and cancer mortality. If you have a look at the human randomized controlled trials, the evidence is actually pretty mixed. If anything, it's almost disproven, say, the link between vitamin D and cancer, for example. So the VITAL trial is the trial that I often quote on my channel, that looked at you know, cancer, cardiovascular disease, and essentially there was no benefit from vitamin D. But if you have a look at the observational data, that's when it looks really positive.
And I think, I mean, again, interested to get your take. My view on that is all of these are imperfect, right? Even clinical trials they're way imperfect. I think sometimes people put too much faith in a single clinical trial, and that being the absolute truth. The reality is you kind of have to take all of the data that's available and try to come to some sort of, the way I think about it is, probabilistic understanding of what is most likely to be true, right? Recognizing that can change. I do want to double click though on what you said about making a mistake. I mean, I think, first of all, I feel the same way. Like, I want to do everything I can to be accurate and precise and get things right, recognizing you're going to make mistakes. And when you do, and somebody calls you out, and they will, that you're okay with going back on and saying, hey, got this wrong. Here's where I got it wrong. Here's what the evidence actually says. Which again, I think in some ways differentiates the people who are really trying to do the best job they can from the people who are just after clicks, who don't care if they get it wrong, right? Yeah. And there are plenty of those folks out there. We won't name names.
Yeah,
well, you can name names if you want to.
I'll stay out of that controversy. But yeah, it's absolutely right about getting things wrong and then making an amends for it. So, for example, you know, I got resveratrol wrong. I used to take sulforaphane supplements. I used to take, you know, metformin. There was a bunch of things that I got wrong, and to be honest, I got them wrong because I deviated from my clinical background and from my clinical training. So when I first started my YouTube channel, even though I had, you know, 6 years at medical school, I was a junior doctor at the time, you know, and all of that training, there's a huge emphasis about how to interpret clinical trials and make sure that you factor for all the different potential biases and things. When I started my channel and I was looking in the aging field, I kind of got led astray by certain individuals or certain groups who were taking, you know, X, Y, or Z. And I was thinking, well, since they are experienced, and, you know, since I was a junior doctor at the time, I was used to following, you know, my elders, as it were. So, yeah, I obviously got that completely wrong. And I think people have appreciated that on my channel, that I'm not afraid to say, yes, I got it wrong. Here's why I got it wrong. This is what I'm changing.
Right. Yeah, absolutely. And I mean, first of all, a lot of people got fooled by the resveratrol story. And again, you see that quite a bit. And it's frustrating and unfortunate that some of the big names, particularly people who are well credentialed, who are medical doctors, have very large followings, continue to misrepresent some of the data in the biology of aging, longevity space, that by now they should know better. And I kind of look at that and I can't help but ask myself, is it that they don't know better, in which case that's a real problem, that these people have such a large podium and they're communicating bad information to people? Or is it that they do know better and they choose to keep presenting bad information? And I obviously don't know the answer, but I was tempted to name a name, but I've already talked about this on the podcast. There's a very, very high profile medical doctor who continues to get fundamental biology of aging literature wrong and presents it incorrectly. And it's just, it's unfortunate.
I'm not too sure the person that you're referring to, but is there a particular topic that they are getting wrong?
It's related to sirtuins and resveratrol.
Okay.
And it's somebody whose name might rhyme with Clark Lyman.
Right. Yeah. Yeah. I don't tune into that person's content too much, I must say.
So let's go off of that topic and talk more about. Well, let's talk about rapamycin, because you and I have an interest here. You a few years ago now became very passionate about the idea of testing rapamycin in the context of exercise response in healthy older people. You tried for a long time to raise funds for that, were successful in doing so. Combination of philanthropic support, I believe people who watch your YouTube channel could donate, and then you put some of your own resources towards this. Again, I think that's kind of unique, and I mean, I don't know your financial situation, but I'm pretty sure you're not a billionaire yet.
Far from it.
And so you were willing to put up a sizable amount of money. I'll let you share that if you want to. I'll just say, I know the dollar amount, and it's pretty big, of your own money to support this clinical trial. That to me shows a level of integrity that you don't often see. So kudos to you for doing that, and you were successfully able to get the trial funded. So maybe talk about that trial, what it was designed to test, how it worked, and where it's at.
Yeah. So and I appreciate the kind words. Thank you. So the impetus for my interest in rapamycin was from the interventions testing program. So over and over again, when the interventions testing program trialed rapamycin, we see these lifespan extension effects in both male and female mice. But in clinical medicine, rapamycin's got a bit of a dirty name. So it's used as an immunosuppressant. So if you needed a kidney transplant, one of the drugs that you'd be on to make sure that your immune system isn't rejecting that organ is rapamycin. So naturally, there's the concern that if we get the dose wrong, rapamycin may have immunosuppressive effects for otherwise healthy individuals. So maybe would be increasing, infection rates or cancer rates. Now, luckily, there has been some human clinical trials showing that if we actually get the dose of these mTOR inhibitors correct, that those risks can be managed. But there's still that lack of evidence there in terms of translating those exciting findings from the preclinical world with rapamycin into otherwise healthy individuals. So then I was thinking, well, I don't want to do a lifespan study because we'll be waiting decades for that to be done. So what is something that we can measure that's a functional outcome? And what I mean by that is what's something that would genuinely improve the health of patients sitting in front of me at the clinic? What's something that we can measure that rapamycin may impact and improve? And when I was looking through the research, I got interested in muscle performance, particularly how it drops off as we get older. And one of the things that older muscle seems to do is overactivate mTOR. Mm-hmm. And if you're overactivating mTOR, then potentially you're not activating other processes such as autophagy, so the cell clearance process. So the theory is that if we can dose rapamycin correctly, if we give it, say, once a week or however often, we can switch mTOR off, allow autophagy to happen and clear away those old damaged components. Then if we exercise, we can rebuild those new components and reactivate mTOR. So we designed a clinical trial, and thanks for your input on this, to explore that idea that if we combine exercise, so Monday, Wednesday, and Friday, and then give rapamycin once a week on that Saturday at a 6 milligram dose, what will that do to muscle performance? So the primary outcome here was the 30-second chair stand test. And that's quite important because we wanted to have a functional outcome that's quite sensitive for power in older adults. So that's why we chose that one. And yeah, it took a lot of time to fund. It was only a 40-person study, but it took about 2 years to get this funded. So yeah, there were very generous people on YouTube who funded or helped with funding. VitaDAO also trumped up some funding. And then there was still a shortfall at the end of this. So, because the trial itself, and I haven't actually disclosed this before, but the trial itself cost somewhere in the vicinity of about $500,000 US to get done. So we were only about a quarter of the way through after 2 years of trying to fundraise. So on the back of that, I realized that this wasn't going anywhere. And so I wanted to create, first of all, a supplement line, because not only, was I taking a few supplements and I wanted to combine that into one supplement so it was easier for me to take, but I was also thinking that if we divert any potential profits from that supplement line into clinical trials, such as rapamycin, then we can help to bridge the gap. Then there was another funder that managed to come on board, but we were still left with about $150,000 shortfall for the study. And that's, where my wife let us remortgage our house.
Wow, that's amazing.
To get the study underway. And I'm really pleased to share that we've now completed the study, we've written it up, we've submitted our results for peer review. Once the peer review process is finished, then we can announce the results to the world. And I think they're quite exciting results. And I think they give us a really interesting direction as to where to from here, to try and see how we should be dosing rapamycin in otherwise healthy individuals, to see what we can do for muscle performance.
Yeah, fantastic. Your wife sounds like she is highly supportive.
I'm very lucky to have my wife. Yeah.
Yeah. That's wow, mortgage the house to support the rapamycin clinical trial.
Yeah. So yeah, still paying that one off. So.
So the dose in this case was 6 milligrams once a week. I mean, I know how we got there, but maybe you can tell the story of like why that dose, and what's the rationale for thinking that that's going to be beneficial for exercise or muscle performance?
In some respects, it's a bit of a shot in the dark because we do lack that human clinical research, hence our study. But in terms of why we wanted for once a week dosing, so we wanted to have periods of time where we switch mTOR off and again allow for autophagy to happen so that we can clear away those old damaged components.
Rapamycin is going to inhibit mTOR, turn it down, boost autophagy.
Correct. Yeah. And then hopefully most of that rapamycin is out of the system by the time that we start exercising again on Monday. And that's when we can reactivate mTOR through exercise. So hopefully that switching on, switching off will help to rebalance mTOR, and maybe we can see the positive effects of it.
Right. And worth saying, you need mTOR to be activated in order to build new muscle, right? So that's the concern that people have raised, as you know, about rapamycin in the context of muscle function, was that it might actually impair muscle function during aging. Now, the animal data seems to show the opposite, that mice and rats on rapamycin have better muscle function with aging. But in the human clinical literature, I think there's not a lot of evidence one way or the other at this point.
No. And again, it's a gaping hole that we wanted to plug with this research. And this is one of the big reasons why I was so passionate about, first of all, getting the study up and running, but then also plugging that funding gap, because big pharma aren't going to fund these types of trials.
No, they're not interested.
So it's going to require, some out of the box thinking to actually get this line of research done.
Right. Great. So paper's been submitted, under review now, hopefully published in the next couple of months. But boy, I've been through the peer review process enough times to know it's hard to predict what's going to happen. So
well, they haven't rejected it yet, and it's been with them for a couple of months, so that's a good sign.
Great. And so any plans to do other clinical trials at this point? Or?
Yeah, so I've had the daft idea to start a PhD at the University of Auckland, looking at rapamycin. So this initial study that we did together isn't part of my PhD. We'll be looking to do another trial based on the results from our initial study. Because again, I think the results that we've got give us quite an interesting direction to take this line of research. And it also helps, since this is complete, non-for-profit, there's absolutely no money to be made with this research. So the University of Auckland is more than happy to be a sponsor for it. So people who want to donate to the study, 100% of the funds will be going towards the study. So the university isn't actually taking a cut.
That's
which is
pretty,
wonderful. Yeah.
atypical,
Yeah,
right?
yeah. So again, one of the reasons why, yeah, very lucky to work where I am, and the University of Auckland have really stepped up here.
And if people want to donate, where can they go to donate?
Since it's through the University of Auckland, I need to put them in touch with particular people at the University of Auckland. So if anyone watching did want to donate, please, email me or reach me through my website, and I'll be able to put you in touch with the University of
And
Auckland.
what is your website?
So it's drstanfield.com, so drstanfield.com, or my YouTube channel. My contact details are there as well.
Yeah, guys, donate so Brad does not have to take out another mortgage on his house.
Yeah.
Okay, so this is interesting. So you decided to do a PhD. Why? I mean, you're an MD. You've got a successful, I don't know if it's a side business, but you got a successful YouTube channel. You have a supplement product. Why do a PhD at this point?
So I think it's one thing to present the findings of different clinical studies that have been done, but I kind of want to be involved in the actual data creation.
Yeah.
Particularly when you look at how some of the studies are being done, they're not exactly robust in their methods. So I wanted to, make sure that the data that we produce is rock solid, that it's, so there's a checklist called CONSORT, and basically that's a checklist to make sure that the clinical trials that you do have very little bias in them. So there's particular ways of how you randomize, of how you blind the different groups in terms of, who's taking the placebo or the intervention. There's a bunch of things like that I really wanted to try and bring to this field and make sure that we're evidence-based. And I think the best way to do that is via a PhD, because not only do I have, supervisors at the University of Auckland to help guide through this process, because, there's still a lot for me to learn as well. But also, it does help with funding through the University of Auckland as well, again, through that donation mechanism. So, that's sort of long story short as to why I want to do it.
How long does a PhD typically take in New Zealand?
At least 3 years.
Okay.
Yeah. So, but it's what I want to do with my career. So it's
sure.
It's not a destination.
Like you're thinking about like the time
exactly.
commitment. I was just wondering because in the United States a PhD is typically 5+ years.
Right.
So
I think the typical way to do it is that you have to first have a master's and then you have to go and do your PhD. So that entire process is 5 years.
Yeah.
But since I've already got the MD,
right.
I can shortcut that.
Thanks.
Yeah.
All right. Well, I'm excited to see what comes out of your PhD thesis as well. So let's talk a little bit about your perspective on healthcare and preventative care. I mean, we've had offline conversations about this. And I know one of the things you've suggested to me several times is that so my perspective is that there is a cultural misalignment in healthcare, primary care in particular, where the perspective does not start from keeping people healthy. It's reactive typically and waits until people are sick. And I'm obviously looking at this through the lens of my experience with primary care in the United States and what I know of primary care in the United States. You're in New Zealand, and you have suggested to me that in your experience it's very different, that the primary care, maybe you would say even starts at prevention, but at least has a significant preventative component. So I think I just laid out for you my understanding of your perspective, but maybe tell from your experience, like what's different from seemingly the way things are done in the US versus your experience in New Zealand.
So my experience in New Zealand is that primarily we've got a public healthcare system, and one of the big areas of emphasis is trying to prevent people going into hospital in the first place, because it's just so expensive for the government. So if we can work hard at a primary care level to prevent heart attacks, to prevent strokes, that's far more cost effective compared to treating heart attacks and strokes and cancer.
And so the government actually is encouraging primary care physicians to take a preventative approach.
And through my training as well, since it's all kind of tied together in the New Zealand system, there's a heavy emphasis on prevention. Yeah, so that's the sort of culture that I come from, and it's then quite jarring to hear what's happening potentially in the US.
Yeah,
where it's not quite like that.
I wonder if some of it is cultural. I think talking to a lot of MDs, they don't really get much in the way of preventative care education in medical school. Some of it's probably incentive based in that the hospital systems are incentivized to do expensive procedures and have people in the hospitals. And while our government pays a significant portion of that burden, it's not as direct. So maybe it's a combination of both culture and the incentive structures in the U.S. healthcare system.
Yeah, so on that point, I think Warren Buffett says this: show me the incentives and I'll show you the outcome.
Absolutely.
Yeah. And so, yeah, I think this is the conversation that we've had sort of on potentially my podcast and offline, is I think this is a funding issue, where I think if the emphasis is placed on prevention to try and overall reduce the costs of healthcare, because there are these famous graphs of the US healthcare system, and it compares to the rest of the world, how expensive healthcare is in the US compared to the outcomes that you get.
There,
Exactly, yeah. And I think that's because from essentially what you're telling me, and also from what I've heard from other people, that the incentives are, if the hospitals will get paid a lot of money if they treat people within their hospital system, whereas there's not really any money diverted towards preventing that person getting into hospital in the first place. Right. And that's quite different in New Zealand.
And there's an odd, and I mean, I understand how and why this system evolved with the insurance companies and the payers. What I still have trouble understanding is you would think the insurers would recognize the value of preventive care and keeping people from needing these very, very expensive procedures, or the last 2 years or even 1 year of life, which is hugely expensive, focusing more on keeping people out of that. And yet they don't, right? And again, in the United States, there is a culture among the public of, if my health insurance doesn't pay for it, I'm not going to do it, right? So there's a lot of factors that are at play here, and it makes it really challenging to change the system. So it's encouraging to hear that things are different in other parts of the world.
I mean, it's certainly not perfect, but
no.
I'm very lucky to practice medicine where I am. And one of the things that, because most of it is publicly funded, there's a lot of guardrails in terms of what I can do as a primary care physician. And so it just means that there are certain tests that I can't order or that the government won't pay for because I'm a GP. But I think that's it's a good thing. I spend a lot of time on my channel talking about what tests people should be doing versus what tests are potentially a bit of a waste of money, because there's this idea that people have in their minds that more data is better, whereas that's not always the case. So let's take vitamin D, for example. So there has and still is a big push to do vitamin D blood tests. But the Endocrine Society, they recently came up with their latest version of their vitamin D guidelines. And essentially they say, look, we don't know how to interpret these vitamin D blood test results, because in the clinical trials, when we dose at, say, 800 international units of vitamin D, we seem to lock in the benefits for most individuals. There are some, say, for example, pregnant women, where the dose needs to be a bit higher at about 3,000 international units. But the vitamin D result doesn't seem to correlate particularly well with outcomes. Whereas the dose...
What do you mean the vitamin D dose doesn't correlate with...
No, the vitamin D blood test result doesn't seem to correlate particularly when you try and change that result. So say, for example, if someone's taking 1,000 international units of vitamin D and they do a blood test and their vitamin D on their blood test says that they're probably a bit low and they should up the dose of their vitamin D supplement, there doesn't actually seem to be any significant benefits that we've seen in the clinical trials so far of that approach.
But very few clinical trials actually measure vitamin D levels. That's been my criticism of a lot of the vitamin D clinical trials, is they dose at a single dose, don't actually measure, so they don't actually know where vitamin D is in people's...
Yeah, so I think that's a really valid criticism. The pushback to that is that there have been different dosing studies that have been done, and there is potential evidence of harm at the higher doses. So at higher dose here, I'm talking about 4,000 international units.
I don't have any criticism. I mean, yeah, that's probably true. But even still, if you don't measure, how do you... Because people are variable, right, in terms of how much vitamin D they're going to synthesize endogenously, how much they're going to get from the supplement, right? If you don't measure, how do you know at the individual level? I guess I don't understand how these correlations or lack of correlations can be made if we don't actually have the individual measurements to support them.
I suppose that the pushback to that is that at the higher strength doses of vitamin D, we've not seen any signal of benefit in the randomized clinical trials.
Maybe it's too high. Maybe if you measured, you'd see it's too high. Like, if you don't measure, how do you know?
From the retrospective data that we've got, and again, appreciative that it's retrospective, the vitamin D blood test levels don't seem to correlate particularly well with outcomes.
I hear you say that. So again, it's my impression. We should actually get the data it's my impression that very, very few studies have actually measured.
Correct for the randomized clinical trials. For the
Right.
retrospective data, that's slightly different.
So you're talking about when you just look across a population, you get their blood test. We don't know why they got the blood test necessarily. So that could be a biased population of people who are actually getting the blood tests, right? That there is no obvious connection between measured values and outcomes.
When you correct for different variables. So say, for example, older adults that might be in a rest home or private hospital, for example, commonly they will have quite low vitamin D blood levels. So there's been the question, was it the low vitamin D blood tests that maybe caused them to go into the rest homes in the first place? Maybe if we had dosed them with vitamin D, they wouldn't have needed that care. But it's actually probably the opposite. It's more that when they go into these rest homes and private hospitals, they're spending a lot more time indoors. So it's more of a marker of frailty rather than an actual cause of frailty.
That's one of the challenges with trying to do those kinds of analyses.
So the overall point is that the retrospective data that we've got hasn't been particularly encouraging for vitamin D blood tests.
I don't buy it. I would say are probably so many problems with that data that it is likely not informative. And I think this is where you and I have a disagreement about how much we should trust things like the Endocrine Society or these boards of medical experts who come together to offer opinions. Because my view is they often start from the point of being hyper conservative, and it takes a lot to move them off of that position. So here's my take on vitamin D and other things. If we actually believe we have some idea what the optimum level is.
I don't think we do.
Okay, well, that's a different question.
Yeah.
But if we think we know somewhat what the optimum level is for anything, and we have the ability to measure it, and we are going to be supplementing or doing something to try to move people to the optimum level, we should measure it, right? So it sounds like the difference is you don't think we know where to target people for vitamins.
So that's one of the things that the Endocrine Society highlighted in their latest review, is that we don't know what level to go for. So the analogy that I use in my videos when I talk about this is that it's a bit like a baker trying to figure out what temperature they should be cooking their cake. They don't know what temperature to go for or aim for with vitamin D. So what's the point in even trying to measure if we don't know the optimum level?
What's the point in
yet?
supplementing then?
So it seems that if we supplement at 800 international units, we seem to lock in any potential benefits for bone health, for immune function, etc.
At the population level.
At the population
But you have
level.
no way to predict which individuals are going to get that benefit.
Well, there's no evidence at the moment that higher doses offer us any further benefit, though. So even retrospective data calls into question whether there would be.
But
any
was
benefit
everybody in those retrospective studies getting a supplement?
Well, so the retrospective studies that I'm referring to were looking at blood levels.
Right.
So,
and was everybody getting a supplement in those?
I'm not sure.
Right. Probably not. Right.
Yeah.
So again, it's a limitation to the data.
It is a limitation, but I think it's. So one of the things in primary care that we have to be mindful of is costs.
Yeah. Okay.
So
this is getting to the crux of the issue, right? Is the diagnostic worth the cost at the population level if the government's going to pay for it? That's a different question.
Well, no, if anyone will pay for it. So,
but if a private individual wants to pay for it, it's their own money.
No, 100%. So anyone can purchase whatever blood test they want and can supplement with whatever they want to do. But I think at the population level, most people are struggling for funds. So the clinic that I work at is not in some ways it's quite an impoverished area. People aren't well off. They are single mothers or they're working 2 jobs. So to encourage that person to then pay for a blood test that there's no evidence at the moment that we've got that getting that blood test result and trying to optimize that level will offer them any further benefits, that's quite a tall ask. And one of the things that we also have to try and do, it's a bit of an engineering term, but it helps to explain this concept. The best part is no part. The best process is no process in terms of error rates. So if we can remove things from that don't actually shift the needle, or maybe shift the needle a tiny, tiny amount, if we can then redivert those resources to other things that really do shift the needle, that's more interesting. And that's what primary care has to try and balance. Yes, we could try and order all of these tests and optimize every little thing on a computer screen, but will that actually improve the health of the person sitting in front of me? Probably not. There are a few things that do make a significant difference, and those are the things that we try and focus on in the limited time that we've got.
Yeah, I think that context is really important, right? That when you are resource
Mm.
constrained, you have to make decisions about prioritizing how you're going to allocate those resources. And the decisions have to be based on where you think you're going to get the biggest impact for the limited resources. And I think there, and again, maybe it's different in New Zealand. In the United States, there is absolutely this culture of starting at do nothing, and the bar to get to do something is quite high, right? And so, where do you land? I mean, I'd be interested in your thoughts, but more broadly, where do we land in that that question of when to act versus starting from the perspective of don't act, right?
Yeah, so there's this concept that was drilled into me in medical school, which is this phrase of motivational interviewing. So it's trying to make sure that the person sitting in front of me is self-motivated. So some people have got no inclination to look after their health. And, I could try and say, you should do this and this and this, and that's not going to get anywhere. At the end of the day, it needs to come from the patient within. So the idea behind motivational interviewing is to see what steps that the patient can come up with themselves that will actually improve their health. So some people are really on board and they're exercising and, having good diet habits, and they're, taking medications if required. Other people, with motivational interviewing, it tries to figure out, is there one small thing that we can focus on today that's going to start them on a really positive health trajectory? So it's trying to nut that out. So yeah, it is a challenge. And a lot of patients that I see at the clinic, that they don't want to look after their health.
Sure. Yeah. Okay. I want to come back to vitamin D with the question and then we can leave the topic. So let's say and I don't know if the units translate perfectly, but in the blood test you get in the United States, right? I think the guidelines are you want a vitamin D level of between like 40 and 60 or something like that. Some people say up to 100 is okay. You get above 100, it's toxic. We can talk about the specific numbers if you want to. The question I was going to ask you is, if you have someone come in and you don't have to give them the vitamin D test. They've got the data and they're at 10. Are you going to supplement them?
Or
what if they're already taking a supplement?
So for most people, I think it probably does make sense to take a small dose of vitamin D. And that's because most of us are working indoors. And if we do go outdoors, we're wearing sunscreen.
I agree with you there. Let's say they're already taking a small dose. They come in, they've got the test, they're at 10. Would you up the supplement dose? Or would you be guided by the data says that you don't get any added value?
So I would put it back to the patient. I would say, look, this is what the Endocrine Society says. And that would probably be my recommendation. However, it's your health, your decision. So if you wanted to up your vitamin D dose, I can help you try and do that safely. If you are happy with your vitamin D dose, we can leave it there. So that's the point where I'm putting it back on the patient. It's called patient-centered care. So it's not for me as a doctor to tell patients what to do. It's up to the patient to figure out what they want to do, and for me to sort of guide them along that journey. Long story short, I wouldn't tell the patient what to do. I would show them the data and have that conversation with them.
I see that perspective. Again, I guess this is my sort of disdain for medical societies and the decisions that they've made in the past, and my disbelief that they make good decisions now, that I would trust the Endocrine Society to be right in this case. And so here's a different question. For yourself personally, if it was you and you were supplementing with vitamin D and you tested and you were at 10, would you increase your supplement dose? Or would you trust the Endocrine Society?
So I've never done a vitamin D blood test, nor have I ever tested it in one of my patients.
Okay, but let's just say you did,
yeah,
and you came in at 10.
I personally would just leave it.
Okay.
Because we don't know which levels we should be aiming for.
Okay,
yeah. But to double click on your point about the Endocrine Society and other societies that come up with clinical guidelines. Say with Endocrine Society, you've got the best specialists who treat patients and who look at clinical data and trials all of the time, coming together to figure out what is the best strategy.
Aren't these the same folks who said that women shouldn't get hormone replacement therapy, and we lost a whole generation of women who suffered without hormone replacement therapy?
So there were significant concerns initially with hormone replacement therapy about breast cancer risks, etc.
And anybody who knows data knows that was a flaw in the way the data was interpreted. Like, that's all I'm saying. These organizations make big mistakes all the time, and it's.
I don't know if it's a mistake to be cautious.
It's a mistake to be overly cautious and not do a real evaluation of all of the outcomes. Again, even if there was a slight increase in breast cancer, which was the very, very worst possible interpretation of that data, we now know that's wrong. Even if that's true, there were all these benefits that accrued. And to say we're going to make a recommendation that nobody should get this therapy, even though the risk reward was clearly favoring reward at that point. I just don't, again, I think this is a cultural mindset that causes irrational decisions to be made at at among these groups of esteemed,
So I think
decision makers.
So I think overall these societies want to make sure that we're stepping forward, that we don't have to step back. So if they,
But that was a step back. Hormone replacement therapy was already widely in use.
well, no, the clinical trials were still, well, this is what I was taught. The clinical trials were underway, and we had this potential safety signal, and we fully needed to explore that safety
There was a
signal.
large percentage of women who were already on hormone therapy at that time.
I'm not disputing that, but I think there was still that safety signal that needed to be investigated, and I think, um, I think whenever one of these large bodies makes a recommendation, those recommendations are then going to go out to, all GPs, all doctors, and the clinical management is going to change quite rapidly. Then to potentially, if that safety signal was indeed accurate, to try and wind back that decision is quite tricky and difficult to do.
I don't disagree with that at all. I guess again,
But this is why medicine historically, and I think should still be quite slow moving, because we need to make sure that every step that we're making is in a positive direction, because trying to unwind things is a bit of a nightmare.
Is it? I mean, this is we're probably getting into a much larger debate, which I would say two things. One is, it is often the case that the larger benefit cost analysis doesn't get done. When there's one signal of a safety, in this case, let's just even make it more abstract. We don't talk about hormone therapy, right? There's one small safety concern signal, even for something that we know, or we can be very confident has a large benefit. That small safety signal will often be the driving factor in guiding recommendations going forward. And the reality is, many doctors could choose to do that balance themselves, but they don't often have all of the information that's available to these bodies that are making the guidelines.
Yeah,
right?
so I suppose to push back on the hormone replacement therapy benefit. So there are certainly, patients who benefit in terms of, hot flushes or symptoms of that. But there are also other treatments to help with hot flushes and things as well. If we have a look at, other potential cardiovascular benefits, yes, there is a benefit to hormone replacement therapy, but I don't think the magnitude is particularly large.
Does it have to be large? I mean, we could debate how large the magnitude is.
But this comes to the cost-benefit analysis. So you're saying that there's huge benefits to hormone
Bone density, muscle function.
Yeah, but we've got other medications that we can use for bone density,
all of which have side effects. So again, I mean,
but so say with bisphosphonate therapy, the cost-benefit ratio there is heavily in favor of going ahead with that therapy. Whereas with the potential concerns around breast cancer, the benefits of HRT for, bone density, yes, there is a benefit, but the magnitude of effect isn't particularly strong. There was the question of whether estrogen would lower cardiovascular disease, and there's some potential benefit there, but again, the magnitude isn't huge. So I think the societies were correct in just pausing for a little bit to make sure that the benefit truly did massively outweigh.
It wasn't a little pause. It was like 20 plus years.
No.
Yeah.
No, I'm not too sure which data you're referring to.
When did the Women's Health Initiative study come out?
I'm not sure.
It was more than 20 years ago.
Yeah. So
and it's still like 5% of women in the United States are getting hormone replacement therapy, perimenopausal or menopausal women. So it's a tiny fraction. It was probably tenfold higher than that. I could be wrong on the numbers. It was much higher before the Women's Health Initiative. So this has been a full generation of doctors that were trained that hormone therapy is dangerous and did not, in fact, counter-recommended it for the vast majority of their patients. So,
but I think at the time that decision was correct. Again, I think medicine does need to be cautious, because any step that we make, we need to make sure that the benefits do truly outweigh the risk.
But here's the thing. The risk in this case was the harm done to all the women who had a therapy taken away from them. All I'm saying is I don't think that was taken into consideration when that decision was made. And we can disagree. My view is, looking back, and of course hindsight is 2020, that was a bad decision. And groups that make bad decisions repeatedly, I have trust problems with. Just
Yeah.
blanket saying we're going to go with their guidelines.
Again, I don't think it was a bad decision. That they do make mistakes, but I think overall they are probably the best guide that we've got at the moment. I think there are certain clinical doctors that go outside of those clinical guidelines, and I think, you know, that can be a bit cowboy medicine, where they're doing things that are way off base, that aren't evidence based,
Sure.
because they've, you know, potentially misinterpreted a study, etc., etc. I think most of the time at a population level, doctors are far less likely to make mistakes if they follow the clinical guidelines. Not rigidly, because there are certainly times when you need to deviate from the clinical guidelines, but I think most of the time we probably should be following these guidelines that have been written by experts in their fields who are practicing physicians and review the data, and again are at the top of their field. And it's not just one person; it's a group that's coming up with those recommendations. Yeah. So I think that's the least bad option that we've got at the moment. I'm not saying it's perfect, but I think it's the least bad option.
I think that's fair. Again, I obviously we have different perspectives on how much we should trust academic committees. I guess I have been on enough academic committees that
but not clinical academic committees, right?
I've been on a couple of clinical academic committees.
Which ones?
So when I was at the University of Washington, I was in the medical school in the Department of Pathology and Laboratory Medicine, and so we had several departmental committees that were involved in developing recommendations around diagnostics. I've also been on clinical trial committees, so it's a different ball game, right? But you are utilizing the guidelines that have been developed, and you are decision making among a group of academics, and so I'm quite confident that the decision making process is not dissimilar to other academic committee processes.
Again, I certainly don't think that this process is perfect. I think it's our least bad option at the moment, though.
We really don't have any other options, though, right?
I mean, the other option is for for other groups to try and take this on and create their own guidelines.
Yeah.
And I think I worry when that starts to happen, because I think the chances of those guidelines misinterpreting the actual clinical data is much higher compared to, say, the Endocrine Society.
So you mentioned doctors that don't follow the guidelines, and I would agree with you there as well, I mean, obviously it's a spectrum, right? But that there are certainly a number of medical professionals in what we'll call the longevity space who are doing things that are well outside the guidelines. And I'm sure you fall, you would consider yourself falling well within the guidelines. Like that's your first place you go to look. So what are your biggest concerns in the space right now when it comes to whether it's therapeutics or approaches that people are taking that you find concerning in the longevity, wellness, functional medicine? I mean, it's sort of all overlapping these days.
I think one of the biggest concerns I've got is biological age scores.
I would agree with you. I don't know that I mean, let's dive into that.
Well, so
yes.
so not only are those tests that they still need to be clinically validated, as in, so what I mean by that is, say you get a particular result from a biological age score. And from that, your physician says, well, you need to start taking this supplement, or you need to be doing this because of your biological age score. And that's where I get concerned, is that it starts to be used in decision-making processes where the evidence just simply isn't there.
Does it though? I mean, that's an interesting perspective, because my perspective I agree with you completely, by the way, about the biological age clocks, has been that you can't make decisions based. Like there is no information there to guide decisions.
Yes, but that doesn't stop people still doing it within these clinics.
Yeah. So I'll tell you my take, and you tell me if you disagree with me on this. A medical professional should never recommend a diagnostic or a test, number one, that they don't understand at some level how it's working. You could debate whether you really have to understand it if it works, but I think it would be nice if the medical professional understood the test. Some docs do. You probably do, but most don't. You don't know its accuracy or precision. I think that's non-negotiable. Right? If you're going to be recommending a test, you should know how close is it to the true value. And if I do one measurement, what's the error bar on that measurement, right? We don't know that for these biological age tests. And it should drive, in some way, inform patient care. And I think that's what you're getting at. These don't, or they shouldn't. So it's my opinion that no doctor should be recommending these these tests, and it's actually irresponsible to.
Yeah, I think they're interesting research tools in clinical trials, but
Yeah, absolutely.
yeah, but I don't think that there's nothing that I would change in terms of managing a person's health to try
Yeah.
and prevent disease
So
based on these age scores.
what do you do when a patient, I'm sure some of your patients come to you and they want these tests? How do you handle that?
Well, so again, it's patient-centered care. So I would say, look, we're not necessarily going to change our management in terms of trying to prevent heart attacks or strokes or cancer based on what the score says. But hey, if you want to spend your money on this test, that's entirely up to you. And we can, if that provides you motivation to exercise or whatever, then great. We can work with that. So yeah, it's not for me. Like I've already mentioned in this podcast, it's not for me to tell a patient what to do. So if they want to crack on with the test, I will try and support them as best as I can.
It's an interesting perspective, and I'm sure there are absolutely lots of docs in the United States who take that perspective as well. But historically and traditionally, and you still meet a lot of doctors who have a much more paternalistic view, right? Like, I'm the authority, you do what I say, right? So it's a very different mindset, right? That you take.
So during my training as a medical student, there was a lot of time spent about the battle between paternalism and autonomy or patient autonomy, and at that time there was a big shift towards patient-centered care, that doctors should not just be telling people what to do. So hopefully the United States is doing that as well.
I mean, there are some. I'm not aware of like much in the way of medical school curriculum that is spending a lot of time focusing on that. Again, I think that I guess my feeling would be somewhere in the middle, and I'm sure that's what you actually do, right? I mean, you do have a knowledge base that most patients aren't going to have that should be guiding recommendations, but also the person needs to be invested in their own health, right?
Yeah. And often patients will ask me, well, what do you, as in me, recommend? And I say, well, based on this evidence or based on these guidelines, I would suggest this. And they often say, well, yeah, that's fine. Particularly on my computer screen, I can show them what the data shows or what the clinical guidelines show. And I think patients appreciate that I'm actually quoting clinical data rather than, just making stuff up, which, and clinical guidelines change. And particularly in today's age where clinical trials are rapidly being done, say, for example, with GLP-1 medications, when the weight loss data came out about these medications with Ozempic, almost immediately the clinical guidelines shifted. And we were prescribing these medications and getting patients off insulin, getting them off their blood pressure medications. It's completely revolutionized how we do things. And the clinical guidelines were very, very quick to be updated. And that's one of the reasons I think why Ozempic really took off is because physicians were also pushing it. Well, not pushing it, but mentioning it to patients because the clinical guidelines
and it
were updated.
works, right? I mean, again, all of this is tied together. Those drugs work so well. Docs see it work for their patients. They're going to recommend it. I was going to ask, but the clinical guidelines, do you think that was unique to the GLP-1s because of how effective they are? Or do you think this is just a shift in the ability of these guidelines and the organizations to react to
so
new data?
I'm more optimistic, I think, than you. When a high quality study is done, so for example, it's well powered, we can see a true statistically significant result that's clinically relevant as well. So this is quite a distinction, I think, that people should be aware of. Yes, you might see a statistically significant result, but if it's a clinically small effect, doctors aren't necessarily going to get too excited about it. Whereas with GLP-1 therapies, not only was it statistically significant, but it was a clinically massive effect. And it was a high-powered study, as in there was a lot of patients in that study. And GLP-1 therapies had been actually used for a long period of time. I think they were first used in 2007 or 8. But the actual weight loss study for non-diabetics, that's what really started to revolutionize things. So because of that strength of data, that's why the clinical guidelines were updated so quickly. So one of the clinical guideline databases that I rely on is uptodate.com. And within those clinical guidelines, they've got a section, it's simply titled What's New or Practice Changing Updates. And that's, as soon as a high-powered clinical study comes through that's past peer review, the clinical guidelines are automatically updated. And so that's a wonderful resource that I use with my patients. And obviously, since it's US-based, I'd imagine that a lot of US doctors are using it as well.
How do you judge I mean, you talked about some of the criteria, statistical power, number of participants in the clinical trials. How do you judge the quality of the clinical trials? I think that's really important because you alluded to this earlier. There are a lot of clinical trials carried out that are not to the highest quality. Certainly, if you have the time to go through and look in a very detailed way at what was done and how it was done, and did they,
But this is what the committees do.
I mean, again, there's just a lot of bad decisions that get made. So I don't know.
I think cautious decisions.
Yeah.
Yeah. But anyway, coming to your point about how do we know whether a clinical trial is well done or not, one of the quick ways is to figure out where the study was published in terms of what journal it was published.
Yeah.
So that's sort of a first starting point. But obviously, you can't just take that as gospel. You need to actually have a look at the clinical trial. Now, there are specific criteria for a well-run and reported randomized controlled trial. So they're called the CONSORT guidelines. So most, if not all, randomized clinical trials should report based on that guidelines. This is exactly what we did, for example, with our Rapamycin clinical trial, is that we followed the CONSORT statement to make sure that we had checked everything, not only at the design point, but actually reporting on the and writing the paper as well. So that would be the best way to do it, is to actually get the CONSORT statement next to you. So it's a printout a version and just basically tick it off as you're going through and reading the clinical trial, which takes a lot of time. And that covers things like, funding biases, blinding, randomization, powering the study. It's very, very comprehensive. So it takes a long time to fully analyze a paper well.
So in your opinion, why is it that we, I don't want to say all the time, but not infrequently, have clinical trial results that later trials don't replicate or don't hold up?
So oftentimes those initial studies are underpowered. So even though they'll show a statistically significant result, there's been a bit of statistical trickery behind that. Yeah. So that's one of the potential reasons why. Other potential reasons are sometimes the randomization process isn't particularly good. So the different groups aren't actually relatively equal. Another problem could be blinding of the study. So there's a lot of ways to muck up a clinical trial.
Yeah, and they're hard. Let's be fair.
Yeah.
Now, right? Doing a clinical trial is not trivial.
No, it's not. But the CONSORT guidelines are wonderful. They do take a lot of time to actually set up a clinical trial well. But if you actually follow that guideline, it's pretty bulletproof. Well, not bulletproof, but very, very good.
Yeah. It gives you a solid foundation
exactly.
to build the trial.
Exactly. So that's if a particular study is garbage, it's no wonder that a better conducted study isn't going to show that result. Yeah.
Right. And sometimes even just in a different population, the same medication isn't going to have the same effect.
100%. Right?
Yeah. Okay. So let's talk about some of the interventions that you're enthusiastic about. So we talked offline a little bit at lunch about SGLT2 inhibitors. Maybe you can tell us your perspective on those molecules. And do you think of them as longevity drugs or something else?
I think it's really important to pinpoint exactly what benefit people are going to get from a particular drug or medication, because we have to make sure that the benefits vastly outweigh the risks. So if I told a patient...
But can I hold on there? Did you say vastly outweigh the risks?
Yeah.
Why does it have to vastly outweigh the risks?
So medications always have potential side effects, and sometimes those side effects are much worse compared to others. In terms of... some patients won't get any side effects, but other patients may get significant side effects. So if the risk-benefit ratio doesn't vastly outweigh in terms of the benefit side, you are harming patients. And one of the things that we're taught at medical school is do no harm.
But aren't you harming patients who aren't going to get the benefit if you don't give it to them?
At what cost, though?
I don't know. That's the question. That's why I'm saying, does it have to be vast? Like, the way I think about it, very simplistic, is cost benefit. If the benefit is bigger than the cost, that's a win. Now, how do you do that at the individual level? I get it, but
I mean,
why does that be like this instead of like this?
Well, yeah, I mean, to take an extreme example, if your medication is going to give benefits to half of your people, but for the other half, it's going to kill them.
Oh, sure, but that's also that's where trying to actually calculate like the magnitude of risk. I would say if death is the risk and there is a significant fraction of people who are going to die, that makes your risk really, really big. You're gonna. So again, this may be partly how we're defining it.
But let's take GLP-1 medications, for example.
Sure.
So with GLP-1 medications, yes, they do have significant benefits, but for some patients, it does have significant costs in terms of, nausea, vomiting, diarrhea, those types of things. And for other patients, in very, very rare instances, it can actually cause blindness. So, you need to make sure that you're not going to cause 10 or 20% of your patients who go on the therapy to cause them to go blind. right? So this is why I think you need to make sure that the benefits do vastly outweigh the risks, because some of those risks are massive and have an outsized impact for those particular patients who are effective.
Yeah, I think this may be partly how we're defining risk and benefit, but I understand what you're saying. It's an interesting question, though. What are the right metrics we should use to actually assess risk and benefit? And it also depends a little bit on what's the goal. Like,
Well, it depends on the patients as well. So
sure.
for a lot of patients that I see in the clinic, if we're going to start a new medication, one of the first things that they will ask is, what are the risks? And this is all about making sure that they are fully informed about the potential risks versus benefits. So some people will say, even though there's a tiny, tiny, tiny chance of blindness happening from GLP-1 medication, that's enough for me to say, I definitely don't want to take it. So yeah, it's at that patient level, I think.
I mean, and the reality, though, is most people make decisions based on fear. And so I think that fear mindset is going to have an impact on a lot of people, right or wrong. That's just the reality. That's just human nature. I think part of the challenge that I struggle with is when you think about the benefits of some of these drugs. GLPs are interesting, or let's just say a hypothetical drug that targets the biology of aging. The potential risk is there. It's real. Let's say 0.1% of people are something terrible is going to happen to them, right? 1 in 1,000. The potential benefit, though, is quite large, right? GLP-1 drugs for a lot of people will give them 15 years of health span, probably. We don't know because we haven't had the data yet. But I mean, tell me if you disagree that's a likely outcome.
Taking that hypothetical, depending on the severity of that side effect, even though it might be rare, that's got such a huge impact for that particular subset of patients. So that's why I think we just need to be really careful that the drugs that we are prescribing, the benefits do vastly outweigh the risks. Because again, some of those risks just play such an outsized impact for those patients.
Yeah, I guess this is what I'm saying. How do you calculate that, though, right? What is I mean, every drug has some risk.
Well,
lots of FDA-approved drugs that have
100%, but you put it. So the approach that I'm taught is that you put it back on the patients and you say, these are the potential benefits. These are the potential risks. What would you like to do? And again, it's not for me to tell the patient what to do. So
that very rarely happens. I don't think that's typical at least not in the medical care that I've experienced in people.
Yeah, I think as we've established, the healthcare system is quite different between our two countries.
It's interesting. And I mean, I think I agree completely that giving people the information and letting them make the decision is the right thing to do. It can be hard to know what the actual correct information is at a moment, and it's a moving target with a lot of these drugs, right? Like we don't know the full long-term side effects of GLP-1 agonists yet. We can guess.
These drugs have been used since I think 2007.
Yeah, but in very unique patient populations, right? I mean, they're being used differently today.
Yeah, so those were type 2 diabetic patients. But the point is, it's been well over a decade that these medications have been used. So we do know quite a lot about what will happen relatively long-term speaking.
Yeah, I guess, I mean, a decade is medium term, I would say, to me, for a drug somebody's going to take for the rest of their life. But
say what's the average lifespan in the US at the moment? It's something like 78, something like that.
That's about right.
Yeah. So if someone started this medication when they're 50, average, they're going to have sort of 28 years. So, and we've already got, 12. So we've got 17 years roughly of long-term follow-up with GLP-1 medication. So, that
interesting question. How many people have been on GLP-1s for that long?
Not sure, but it's certainly not infrequent. So these drugs are relatively new to New Zealand just because of the funding, but they've been used again since 2007 to 2008.
For the record, I'm not worried about, no more worried than I would be about rapamycin, the long-term effects of GLP-1s. It's just a question, I think, that often we don't know the answer for a long time.
Yeah, but I suppose to double click on that, we do have a lot of data now showing that these medications reduce cardiovascular disease. Mm-hmm. They seem to slow down kidney decline. So the trends, at least, seem to be heading in a really, really positive direction.
I agree. Yeah. I mean, you and I think, have very similar opinions on GLP-1 drugs.
But so just to close this out, I don't think that in 20 years' time we're going to find this horrific side effect that means that the trends are suddenly skewed in the other direction. Yeah.
And we don't know with 100% certainty.
Yes, but so interesting that you say that. One of the things that that medicine, at least in New Zealand, that was drilled into me, is that we have to be comfortable with uncertainty, because there's nothing that is 100% certain.
Okay, so I started with SGLT2 inhibitors and we got onto GLP-1s, but I mean, both of those, I think, tell me, is it your perspective that these are effective preventative medicines?
Yeah.
And tell me how you think about that in the context of your practice.
So it depends on what we're preventing. So say, for example, in type 2 diabetic patients, when we prescribe them GLP-1 medications, we do see prevention of heart attacks, for example. So in that context, yes, we are preventing, significant disease.
And that's because people on GLP-1s, if you look out over time, are less likely to have a heart attack than people who are not on GLP-1s.
Yeah.
You try to match as much as you can.
That's right.
Else.
Yeah, that's right. But then the question is, should we be using these medications to prevent diabetes in the first place? But this is where, when we start to use GLP-1 therapies in obese patients, so obese patients are already at a higher risk of developing type 2 diabetes. When we give GLP-1 medications to those obese individuals, they are less likely to develop type 2 diabetes. So we're kind of going up the chain here, as it were, that the earlier that we seem to intervene with these drugs, the better long-term effects that we have in terms of prevention. So this is one of the reasons why GLP-1 therapies in certain situations have been used and are used in teenagers, for example. So we're trying to intervene earlier so that we can prevent, diabetes from happening in the first place.
Yeah, no, absolutely. So we had one of the things that came up in our conversation earlier that surprised me was, I think you said, and correct me if I'm wrong, that SGLT2 inhibitors, clinical guidelines now are shifting that they can recommend use of these drugs in pre-diabetics to prevent diabetes. Is that correct?
So the clinical guidelines haven't been updated yet, but there's taking a step back from the diabetes prevention program. One of the studies that they ran was on metformin and what happens when we give metformin to pre-diabetic patients compared to a placebo. And when we do intervene earlier with metformin, we reduce the chance of those patients developing full-blown type 2 diabetes. Now there's increasing calls that we should actually be using, SGLT2 inhibitors or GLP-1 therapies rather than immediately reaching for metformin. Because metformin, yes, it's got a weight loss effect, but it's relatively small. It's about 2 or 3 kilograms. Yeah. Whereas GLP-1 therapies, it's significant. Right. So, there's a growing chorus now that we should be using GLP-1 therapies and potentially SGLT2 inhibitors rather than reaching for metformin for pre-diabetic patients.
I see. But you use SGLT2 inhibitors.
Yeah, my case is a bit different though. So just because of my genetic profile, I've got high blood pressure. So I take an ARB medication, so angiotensin receptor blocker, but that wasn't quite enough to get on top of my blood pressure. So I wanted to add on an additional medication, and I knew about the lifespan extension effects from the interventions testing program, and I liked the mechanism of SGLT2 inhibitors, so I had a chat with my kidney doctor, and he agreed to prescribe me the SGLT2 inhibitor. But I'm using it as a diuretic, as a blood pressure control.
Right. Yeah. Interesting. So that's not the clinical guidelines.
That's definitely not the clinical guidelines. No. The clinical guidelines would recommend other drugs.
So we don't always have to follow.
But this is exactly the point, that the guidelines are there, and most of the time that we should follow them. But for me, and for my own health, I knew that the potential benefits and potential risks of SGLT2 inhibitors. So for me, I wanted to go on that. And I'm
right. And you, being the patient in this case, are informed and able to.
Exactly. And so if a patient that I saw in the clinic approached me and said, I've got, for first line, most patients should be using an ARB, an angiotensin receptor blocker, if they needed that blood pressure management. But if we're at a half strength dose of that and we need to start reaching for something else, and a patient said to me, look, I definitely want to go onto SGLT2 inhibitors, as long as they were fully informed that, and it's not guideline driven, obviously, but this is again about patient-centered care.
Right. Cool.
Yeah.
So I think we're going to have to wrap up here because they're going to kick us out of here in a minute. But is there anything we haven't talked about that you want to?
Oh, so much.
Talk about? We can come back and do this again.
Yeah,
sure.
Definitely. One of the things that, and we sort of talked about this offline, is sort of the causes or drivers of aging, and whether, if we treat the hallmarks of aging, what impact that will have on lifespan, and whether we are close to treating aging. Sorry, I'd love to pick your brain about that.
Yeah, I mean, I think this is a really important question, and one way to sort of frame it is like, how close are we to understanding the biology of aging? Because right now, the hallmarks, most people would say, is our best attempt to sort of formalize mechanistically what is aging, right? Um, and I think within the field, there's a wide spectrum of opinions about, are we 90% of the way there or 10% of the way? I'm very much on the 10% side. So I don't know if you've seen this graphic I use sometimes to illustrate this, but there's a map of the Earth for 500 BC. It's called Hecates's map. And you look at it and it's got like a sort of, there's a Libya, like Libya is really, really big. And there's this vaguely Europe-shaped blob, and then it goes off into Asia, and then you sail too far and you fall off the edge of the Earth, right? That's kind of how we understood the surface of the Earth in 500 BC. And I sort of feel like that's kind of how we understand the biology of aging today, right? Meaning there's a lot that we don't understand. So I'm not optimistic that if we addressed all of the hallmarks of aging, that we would see doubling of lifespan. And we definitely, I don't think, would see, that we've cured aging, right? Other people will say we're much closer. So it's a difference of opinion. But I think it's important to understand two things about if I'm right. Let's say I'm right. If I'm right, there's two things that are important to understand. One, Hecates's map was really useful in 500 BC. People used it to explore and get rich and go to war, right? I mean, we understand enough about the biology of aging that we can use that information in meaningful ways, I believe, to have an impact, at least on health span for lots of people, for companion animals, potentially significant impacts on lifespan. And if I'm right, we should be allocating resources, more resources than what we are currently allocating, to figuring out what we don't know. That's my biggest criticism of the hallmarks. The hallmarks have been great in certain ways, but I think what they
Kind of
did,
narrowed our focus.
they narrowed the focus of the field, or probably earlier than it should have, and made it very difficult to fund research that doesn't fit within the hallmarks paradigm. The consequence being, there are lots of people doing very deep mechanistic dives on genes and pathways and mechanisms that we already understand to some extent. That's great. We need to do that. But basically nobody is doing discovery science in the field anymore. And I think we need to return to that and allocate some resources to what we don't understand. And the last thing I always point to sort of suggest why I think this is the case, if you look at the largest effect on lifespan in a mammal, and we can debate about genetic interventions through development, but in general, it's a caloric restriction experiment that was done by Rick Weindruck and Roy Walford almost 50 years ago now. So if we were really getting closer and closer and closer to solving aging, we ought to be able to increase the lifespan of a mouse by more than what Rick and Roy did 50 years ago, and we aren't doing it.
Yeah.
So it's hard to reconcile that we're really close to longevity escape velocity with the fact that we just don't have any great new tools to impact longevity.
Sounds like we need to get back to work.
There's a lot to be done,
Yeah.
which is good. And when I say this, I don't mean to diminish at all the good stuff that is happening in the field. And I think we are getting closer and closer and closer to real translational impact in the clinic. And we should continue to try to explore, unknown territory and push the boundaries of what we do now.
Absolutely.
We can do both at the same time. We should walk and chew gum at the same time, guys. All right, this has been super fun. Thank you for sitting down. We will definitely do it again. We have lots of topics that we could dive into more deeply.
Thanks, Matt.
Awesome.